This is a topic that we should have done last week. For some reason, I might have gotten my slides all mixed up. So apologies for that, because I have a feeling that your program is kind of synchronized clinical with the lectures, so it might have mixed up a little. So today we are going to be looking at bleeding and clotting disorders. And so before we start, we'll just remind ourselves of some of the basic physiology of clotting. These are things that you probably know already, but we'll just look at it more from a clinical context and also maybe from a laboratory investigative context. So, as you know, when there's an injury, there are three levels of response, as it were. The first is what you refer to as this reflex vasoconstriction that happens at the level of the vessel, and then you get the primary platelet plug that is formed, which is then consolidated with the help of the coagulation cascade to form this fibrin meshwork that will then hold the clot in place. So one of the challenges with clinical practice is that because some things are fairly uncommon, we tend to lose sight of the basic physiology, and we might actually forget after many years of practicing. So it's always good to remind yourself that this basic physiology is just as important, and it helps you to reorient yourself and get you back to your basics. So when I'm referring to this, I'm talking about if you've seen a number of patients with either bleeding or clotting disorders, you find that some diseases are more prevalent than others. And so this epidemiology sometimes can skew your perception of what the problems might be. In as much as we usually would say common things occur commonly, so you might see like 1,000 cases of bleeding clotting disorders. Maybe most of them, like 900 of them, may fall into the category of like maybe DVT and things like that. And so you begin to think, oh, everything has to do with coagulation cascade. So it's really very important to remember these basic concepts. So please remember, reflex vasoconstriction is just as important, which means, so the reason for all of this is to say that if there were to be abnormalities of the vessel wall, that can, and of course you know what the vessel wall is. It has all of those layers you learned in histology. Key amongst them is collagen and some of those other things that you must have learned about. So very uncommonly, you'll find somebody with a bleeding disorder that is due to something like scurvy. You know, a disease like scurvy, vitamin C deficiency, which sort of affects the collagen wall. And so it's very important to bear in mind, reflex vasoconstriction is just as important as all the other levels of all the other steps for clotting to take place. The platelet plug, we can't overemphasize that. I'm sure you know already that if there is thrombocytopenia, it can lead to bleeding, and that's the quantitative part of it. And of course, if there is thrombocytopathy, so that is, the numbers may be right, but the function is not right. So that can also lead to prolonged bleeding. Each of these things will cause different forms of different phenotypes of bleeding. So over time you begin to, these are some of the things we want to remind ourselves of today. I see familiar faces. Okay, good. Also, then we come to the elephant in the room, which is the coagulation cascade. That's the one we usually want to go to automatically anytime we hear of a bleeding disorder. All right. So of course we know that some of these disorders are congenital and some are acquired. and I've just listed a few of the common ones here. So hemophilia is fairly common among males. Not that common really, but it happens, obviously. Von Willebrand disease and other factor deficiencies. Obviously, this is not exhaustive. This is just to highlight a few of the common ones and maybe some that we would speak to as we go along today. Then, of course, there are these acquired ones that are listed here. People with liver disease, DIC, disseminated intravascular coagulopathy, vitamin K deficiency common in neonates, and a few other people. People can also get it from other conditions. Uremia from CKD. Usually that would lead to multiple clotting problems, but key amongst them is thrombocytopathy. Then massive blood transfusion, we'll say a few words about all of this as we go along. If we are trying to look at them based on the etiology, we can look at some that are due to problems with primary hemostasis, some that are due to problems with secondary hemostasis, and those that have kind of like a mixed etiology. So when we look at the primary hemostasis, that will be that part that involves the vessel wall and the initial platelet plug. So all of those lesions that, like we said, that affect the vessel wall, the vasculature, or lesions affecting the platelets themselves, those are the kinds of things that will give problems at this stage. Now, when there are pathologies of the vessel wall, some people have pathologies of the vessel wall that are systemic, probably not as common as those that are more focal. So many vessel wall abnormalities may be focal. People have telangiectasia. It may be a small vessel disease. It may be a medium-sized vessel disease or large vessel disease. So there are different forms of vessel diseases that people could have. It could have to do with maybe maybe some congenital abnormality or maybe some acquired pathology leading to this vessel wall disease. So all of that are things to consider. Now, usually when it involves small vessels and capillaries, you would find that the presentation will be in the form of petechial hemorrhages, pinpoint hemorrhages. That's the one called petechia. And then also it could also be prolonged bleeding and oozing. That can happen especially when it's focal. And so among the congenital ones, telangiectasia is one. Viruses sometimes can also cause vasculitis. You might have read about them in your pathology classes. So some people also have viral vasculitis that can lead to vessel wall abnormalities because of the inflammation. There are many layers of tests that we could do. There are some tests that are more global, and there are some tests that are more specific to different aspects of the clotting process. So when you think of more global tests, a test, for instance, like the bleeding time, is a much more global test because it's sort of non-specific. It tests so many things together. And we'll also talk about the more specific ones as we go along. So usually when there are problems with the vasculature, you might find that there is no abnormality in the laboratory tests because, of course, vessel wall abnormalities will not show up in, like the standard screening coagulation test. So when you do not be surprised that the fact that you have done a coagulation screen and everything is normal does not obviously exclude, but it could potentially exclude some things, and then you might want to focus on some other things. Also, some bleeding can just be physical. Of course, if you do a surgical procedure and you cut through a vessel, it will bleed. So prolonged bleeding may be problems of just physical, anatomical problems rather than pathology. Okay, we've talked about the fact that it could be focal, it could be regional, it could be systemic. Okay. So some examples are listed here. Simple purpura, senile purpura, and all of those things listed. Then some platelet disorders. I think it's important to mention that apart from the quantitative ones, the qualitative one that I was going to talk about is the use of aspirin. Because aspirin causes like a permanent, irreversible platelet dysfunction. Obviously, that will affect platelets that are present in the system at the time when the aspirin was used, which means if you stop the aspirin and new platelets are produced, they shouldn't technically be affected if the aspirin has gone out of the system. But the challenge is the effect of aspirin is permanent on the platelets and it's irreversible. And that's why we use it to advantage when we want to treat people for arterial thrombosis or prevent arterial thrombosis. So I've listed a few things here that could be responsible for thrombocytopenia, maybe inadequate production or excessive consumption or excessive destruction of the platelets. So we have here irradiation, leukemias, myelophthisis, which just means marrow infiltration by whatever process, and then aplastic, splenic sequestration. Splenic sequestration speaks to the fact that platelets, the spleen serves as a sort of platelet pool, and sometimes when it gets excessively enlarged and maybe even pathologic, too much platelets can pull into the place, and then that will take away most of the platelets that are available to function. Multiple blood transfusions or massive blood transfusion can also give a dilutional thrombocytopenia. Okay. So far, any comments or questions? Comments, questions? None? Okay. All right, so in terms of secondary hemostasis, general things to consider are the fact that these disorders are mostly caused by deficiencies of clotting factors, which could also be congenital or acquired. Of course, the ones that we discussed many times are the congenital ones, but in terms of clinical frequency, the acquired ones also are really very frequent because there are many. These days, there are lots of medications that we use, or maybe I should put it this way: a lot of people are on anticoagulation, and other medications could also impact on the function of these clotting factors. So, yeah, we tend to see that quite a lot also. These are more like the acquired or artificial ones. Then, of course, some people also have autoantibodies that are developed that then, that are targeted at some of these clotting factors, which make them to function abnormally or to hypofunction. The manifestations would include bleeding from large vessels, so leading to things like hematorosis, hematomas may form, ecchymosis, and also extensive bleeding following trauma. So in terms of screening for them, I think there is a slide. Is it after this one? Okay. So generally speaking, when we look at the coagulation pathway, I had a slide for it. maybe this one is better. Okay, so when we take a look here, for instance, we can see the extrinsic pathway is that shorter pathway that starts with tissue factor or factor 7. And then there's the intrinsic pathway, which in most books is written, seems to be pretty long. So that part we generally will screen with an APTT test, and the extrinsic pathway will screen with a PT test. And this portion, the common pathway, really starting from fibrinogen, really is what we screen with the TT thrombin time. So when we refer to these tests, maybe it's also important to mention that the PT is generally done with thromboplastin. The PT test is done with thromboplastin. Thromboplastin is a very highly variable reagent depending on the source. And so to standardize it, we tend to use the ISI, International Sensitivity Index, and which then gives you an INR. So basically when we say, sometimes you see people say PT INR, so we're referring to the same thing, PT INR. So the INR is a reflection of a PT, and it's supposed to help standardize, especially when you are comparing results from multiple labs. But if you are doing the test in the same lab, the PT is just as good. Okay, same lab, same reagent, the PT is good. Okay, so abnormalities of the PT would reflect deficiencies of anything in the extrinsic pathway, whereas APTT will reflect deficiencies of or defects in the intrinsic pathway, factors in the intrinsic pathway. And the TT is a reflection of fibrinogen. These days, we actually just measure fibrinogen directly. But remember, when we quantify fibrinogen, it is different from the function, just like many other proteins that you must know about. So when we quantify proteins, remember that it does not necessarily mean the function is okay. All right, so yeah, just to bear in mind. All right, the common hemophilias. So we started with the letter A. So we have hemophilia A, which is a factor 8 deficiency, and then we went to B, factor 9 deficiency, and then we went to C, factor 11 deficiency. I think we stopped with the letters. A and B, factor 8 and 9 are X-linked, as you know, just like G6PD is also X-linked. Any other disease that you remember that is X-linked? Anybody? The guys should know. This is a disease of males. Do you remember anything that is X-linked that you need to worry about? Color blindness? Okay, so it's fairly, of the hemophilias, obviously, hemophilia A is the commonest one. Obviously, that's why I got the letter A, the first one we found. The severe cases are when we have factor levels that are functioning at less than 1%. So, interestingly, when we measure factor 8 function, so again, I'm not talking about the quantity, I'm talking about the function. So many times when we report these percentages, we're actually talking about percentage with reference to normal. Normal in terms of what samples we have for normal at that time. So we report percentages with reference to normal. So you might have like 127%, 130%, all of that is fine. Anything below 50% is considered likely problematic. So when we talk of mild, moderate, severe, it starts basically usually from 50 and below. Okay, so the mild ones, actually when you have factor 8 levels like 5 to 50%, pretty wide, all of that could be mild. When it goes below 5%, so anything between 1 to 5% will be considered moderate, and severe is when it's less than 1%. Okay, and then such people would then have bleeding into joints and tissues, prolonged bleeding during procedures or maybe minor trauma. I think what is key here is to try and recognize the fact that the bleeding is disproportionate to the amount of injury that caused it. Okay, so it's important to bear that in mind. So for the hemophilia A and B, you'll find a prolonged APTT. Okay. And usually the PT will be normal and the TT. So in the lab, there is a terminology that you might hear. People talk about isolated APTT prolongation. So that's classical for these kinds of conditions. So that's what we are showing here. We see a prolonged APTT. When we do a factor assay of factor 8, we'll find it reduced. But in terms of the coagulation screen that you would first request for, you'll find that just the APTT is prolonged. Everything else appears to be normal. So these ones are part of the basic screens that we have when we do a coagulation screen. In terms of severity, we just talked about that. Some of the long-term sequelae of hemophilia includes joint arthropathies, which means joint deformity. We might not see a lot of that these days, unless for people who live in maybe very remote places where they don't have easy access or they were not diagnosed early enough. But so if the diagnosis is coming pretty late, we may begin to see some of those joint deformities, permanent joint damage. Hemophilia obviously can lead to restriction of activity in terms of if we are not able to source the appropriate therapy. If it's mild, we might get away with drugs like desmopressin, which are not necessarily, we're not replacing the factor here. We are just using a drug that will release a temporary boost of factor 8. But in terms of replacing factor 8, we could do it prophylactically, or we could do it in response to some injury or some, and there can also be development of inhibitors, or basically antibodies against the recombinant factor 8 or the external factor 8 that was used to treat the person. So over time, so we've talked about temporary boosts, like with a desmopressin kind of reagent. We've talked about prophylactic transfusions or injections with factor 8. But of course, factor 8 being a protein, you are going to source it from somewhere else. So previously it used to be like human factor 8, plasma derived, or it could be recombinant. The fact that it's just external to the person, they could develop antibodies against it, which is what we would loosely call inhibitors. So when these inhibitors are developed, then it creates a problem, because now you can't give the factor 8 anymore. It's not going to be effective. So progressively, you would find that people who have been exposed fairly early to factor 8, they then can develop antibodies or inhibitors in their system, and progressively the factor 8 becomes less useful, which then brings us to these monoclonal antibodies, which is the most recent discovery or development, and is available in New Zealand. Is being used for patients with hemophilia A. For patients who are diagnosed early, we have a reasonably decent surveillance system for picking up cases as early as possible, and so we can get them onto the monoclonal antibodies before they then go on to develop any of these other big challenges that we want to avoid. We want to avoid all the clinical problems, but at the same time we also want to avoid things like inhibitors developing. Gene therapy has also been tried. It's still, I would say, mostly still in the research kind of realms, not yet not yet widely available for clinical use. So generally, this is what this monoclonal antibody looks like. So if we recall that the factor 8, activated factor 8, basically functions by bringing together factor 10 and activated factor 9. Okay, so they can talk. So this is what it does, and this emicizumab, it's a bispecific antibody that binds to factor 10 and activated factor 9 and does the same thing, bringing them together. But it's not exactly the same. So what it does, it has bypassed that process of something building up. And you can begin to imagine that it has bypassed the process of activation, because we don't get activated factor 8 unless something triggered the process and it builds up until we get to activated factor 8. So if you bypass all of that, it then means that this is constantly in the system, isn't it? And who knows, might potentially, start up something when you don't want something to start. So it's not exactly the same, but it functions pretty well for patients with hemophilia A. You might want to read up a little bit on that. Hemophilia B, also called Christmas disease, factor 9 deficiency, like we said, it's X-linked, is almost the same in terms of clinical presentation. The frequencies are less than hemophilia A, and of course for treatment purposes you have to distinguish between 8 and 9, because you have to use factor 9 to treat hemophilia B and factor 8 for hemophilia A. Von Willebrand disease, this one is not X-linked, so both males and females get them like equally. The gene is on chromosome 12. It's a really big molecule. What it does is to stabilize factor 8. And so in the absence of von Willebrand factor, factor 8, it could appear as if there's a factor 8 deficiency, because factor 8 is readily used up, broken down. So the shield, the protector for factor 8 is no longer there. And so it poses a problem. It also functions by helping to hold platelets to the endothelial surface when the endothelial surface is damaged. So again, it means platelets, that initial platelet activation, adhesion, doesn't happen as well. And so the clotting process, the primary platelet plug, doesn't form as quickly as it should. So bleeding is prolonged, oozing, and just all of that. So von Willebrand factor is a central player. For those who do some football, it's like a midfielder. Just sits in the middle and coordinates things. So if it's missing, there is no link between the defenders and the strikers. Yeah, it's a problem. So it's, like we said, it's needed for platelet adhesion. It's also needed for factor 8 stability. So it can cause a dual hemostatic defect based on these functions that it does. The deficiency of von Willebrand factor leads to a failure of platelets to adhere, resulting in deficiency of platelet plug formation, which manifests clinically as primary hemostatic bleeding and prolonged bleeding time, and a functional deficiency of factor 8 because of, you get the point. Now, the other bit that I wanted to emphasize is this bit here. This is steeped in history. So in the past, when we didn't care how we classify this thing, I'm sure people cared, I'm just joking. So somebody decided that it was smart to call, when there's a partial deficiency, we say it's type 1. When there is a really bad deficiency, like everything is gone, there's none of it left, we say it's type 3. And then for type 2, we apply some letters to it to reflect different forms of qualitative dysfunction. I'm sure you love that system. Yeah. So quantitative defect, partial, type 1, really deep, type 3, and qualitative defects, type 2. And then we have some letters to sort of describe, what sort of function we are getting. Okay. All right. There is indeed one of them that actually just says von Willebrand factor is actually fine, but the part where it binds to the platelet on the platelet is faulty, and we still blame it on von Willebrand factor. It's a very funny classification system, and it makes for a good read. So if you have like an hour someday, look into type 2 von Willebrand disease. It's pretty interesting. I might even make a podcast out of it. Von Willebrand disease will manifest as normal INR, prolonged APTT, and of course, platelet function will be faulty. Von Willebrand assay will be reduced. So von Willebrand assay is sort of like trying to assess the function. Von Willebrand antigen, on the other hand, is quantifying the von Willebrand factor. So that will be reduced depending on the type of von Willebrand disease that you have. And ristocetin assay is sort of like a measure of platelet aggregation. That would also be faulty. So if we stop, you can begin to imagine that if we stopped at the level of basic coagulation screen, it might just look like the hemophilias. If we stop with this first 4 here, and we didn't go on to like platelet function or checking factor 8 levels, So it's important to try and match the phenotype of the bleeding to what you are getting from the lab. So if what you are getting from the lab is looking like a hemophilia kind of picture, but clinically the patient is presenting not like a classic hemophilia, that's one of the reasons people will want to say, let's do additional testing and figure out what this is. Obviously, one clear red flag would be when you have a female that is presenting as if there's hemophilia. Now, clearly, you have to check that out, or maybe it's just mostly oozing and, and there's it doesn't feel like a hemophilia. Okay, no comments. Now, coagulation, bleeding disorders that are due to vitamin K deficiency. The one place where one example I have made is with neonates, but it's important to look at the facts again. So first of all, the source of vitamin K is mostly through gut bacteria, which means if you have a fully developed gut bacteria, whatever that means, like your gut is not sterile like everybody else, then you should have sufficient vitamin K coming from there. And that goes to the liver to help the liver produce all of these lovely factors that are dependent on vitamin K, 2, 7, 9, 10. So the liver makes all of those things nicely based on vitamin K being available. And also vitamin K being a fat-soluble vitamin, just as A, D, and E, means that if there were to be fat malabsorption for whatever reason, then vitamin K can be defective, can be deficient. Or if indeed the liver is faulty, but of course if the liver were to be faulty, it will not be restricted to vitamin K dependent factors alone. It will be like all the other factors, all of them really, except maybe von Willebrand or something. It will be almost everything, right? So it could be quite a journey to try and tease out whether this is just vitamin K deficiency or it could be indeed maybe a liver pathology or some other things. Okay. I think I've also come across a scenario where, so if somebody has cystic fibrosis, which is secretory problems, they also have problems with secreting digestive enzymes responsible for fat absorption. They could potentially have a vitamin K deficiency too, on account of fat malabsorption. So basically just saying, and the reason neonates have vitamin K deficiency is that there is no vitamin K in the milk, which is their main source of nutrient, and their gut is still relatively sterile. So they have a number of things not counting against them. So in adults, fat malabsorption in neonates, all of those things we've talked about. And the results, basically the deficiency results in decreased activity of clotting factors 2, 7, 9, 10, and that reflects in prolonged PT and APTT. DIC, or disseminated intravascular coagulopathy. As the name implies, this is a situation where you have coagulation being activated within the vessel. So let's go quickly back to, there was some, no, not in this. So I think the graphic I'm looking for is in the other lecture. But basically, the way the coagulation cascade functions, the way it is activated is you get some injury to the endothelium, which means the endothelium is maybe ulcerated, denuded, so the layer is peeled off, and then we begin to, the blood is exposed to the subendothelial tissues. All right? So that then means that the platelets, the moment they are in contact with anything other than endothelium or endothelial cells, they begin to, attach, adhesion, aggregation, activation, and all of that will begin to happen. However, in DIC, what we are saying is there is no, the process of coagulation is stimulated system-wide in the absence of, so there's no focal point where there is endothelial injury and where platelets should properly attach. So the coagulation cascade is activated system-wide. And that can happen, as you might recall. So let's quickly go back to this portion here. This one. So here, you see this says tissue injury. Now, even though we put that as tissue injury, but what it means is if there is any process that releases this tissue factor, if there's any systemic process, and that's why the placenta is a big deal here. So when there's placental injury and tissue factor is released from the placenta also contains loads of thromboplastin. So when these things are released from the placenta, that's one of the reasons that is believed that can cause also some toxic materials associated with bacterial organisms also behave like tissue factor, like thromboplastin, and they can also activate the coagulation cascade. So the problem with that is if the coagulation cascade was activated by focal injury, all of these coagulation processes are happening in that locality alone. All the other parts of the body are fine, right? Now, when this is activated system-wide, it then means that all over the body, the coagulation cascade is activated. And the coagulation cascade is not designed for that. if we talk about these factors, the factors in terms of quantity, they are really very low level molecules. Like the quantity is really infinitesimal, really tiny quantities. And the quantities only begin to become amplified as you go along the coagulation cascade. So a tiny amount activates this one, makes a bigger amount of the other one, and then that activates the next one. And then it just begins to become amplified. The quantities are increasing. But when you have a system-wide amplification, everything is used up in like seconds. Okay, so that's why this disease is also called consumptive coagulopathy. Consumptive coagulopathy. All the clotting factors are used up really quickly. All the platelets are, recruited into that process, and they're also used up really quickly. So we then have all the coagulation factors and platelets all consumed. So that's the consumptive part. Now, what that leads to, we have microthrombi, because the process of coagulation cascade leads to fibrin formation. We have fibrin being produced, and it is deposited in all of these capillaries. Of course, when you make strands of fibrin, if they are sitting within the aorta, they will move nicely, freely, just floating through. But when they get to the capillaries, they will settle down there and progressively build up, and that's how they cause system-wide organ shutdown. Okay, so they clog all these teeny tiny vessels in many organs, particularly the dense organs. You can think of the kidney, you can think of all of these dense organs, liver. So there will be micro infarcts all over, and that's why these patients can have multi-organ dysfunction and may progress on to multi-organ failure. Now, having consumed all of the coagulation factors and platelets, then the patient is exposed to bleeding now. We've consumed all the coagulation factors and platelets, we've made loads of fibrin, it's already blocking all the capillaries, and now the patient begins to bleed. So we have two problems. We start with the problem of unnecessary, undue, system-wide fibrin formation, and then we go on to bleeding, which is not controllable because there's nothing to stop it. All the platelets are gone. All right, so the features that we get for DIC include microangiopathic hemolytic anemia, which is happening because these fibrin strands in the capillaries are preventing red cells from passing through. They slice through them, making these fragments that we see when we look at a blood film. So we see fragmented red cells, increased fibrin and fibrin degradation products. An example of fibrin degradation product, anybody? D-dimers, thank you. So D-dimer is a prime example of a fibrin degradation product. So when we measure D-dimer levels, that's what we're checking. Okay, we are checking for. And I think just to clarify also, so D-dimers are useful for excluding, they are particularly sensitive and useful, most useful for excluding the presence of thrombosis. Whether normal or abnormal thrombosis, just any form of thrombosis in the system, if you find normal D-dimers, there is thrombosis is not present. Because anytime there's thrombosis, the enzymes break it down, and so you have these fibrin degradation products. So if you find absolutely normal D-dimers, you can almost be certain that there is no thrombosis. So when we are worried that, like, you have a list of differentials, you are trying to figure out, does this patient have DIC or some sort of MAHA, some thrombotic microangiopathy, whatever terminology, all of those things that mean there's thrombosis somewhere. If you do D-dimer and it's normal, you can exclude all of those. It's pretty sensitive and pretty useful for that. But if it is positive, it doesn't tell anything. It doesn't tell you that there's normal thrombosis or there's abnormal thrombosis. It doesn't say anything. And the magnitude of the D-dimer also doesn't say so much, because we also found that it's some sort of acute phase kind of. It can behave like an acute phase reactant. We found that out in during COVID. So fibrin degradation products, thrombocytopenia will be present, obviously. They will be prolonged, everything, except fibrinogen will be going down. So bleeding time is prolonged, PT is prolonged, INR is deranged, APTT is prolonged, TT is prolonged, and the only thing that doesn't seem to be increasing is fibrinogen, which is being consumed also. So fibrinogen levels are going down. Okay, nothing else to add. Pathophysiology of DIC, intravascular activation of coagulation leading to consumption of coagulation factors, leading to fibrin deposition in microcirculation, leading to secondary fibrinolysis, which leads to bleeding, and that fibrin leads to organ damage and microangiopathic hemolytic anemia. Okay, the causes and the effects. Various causes: infections, malignancies, obstetric problems. We talked about the placenta, and then others, and the effects on the other side: bleeding, thrombosis, acute respiratory distress, renal failure, adrenal necrosis, and all of those things. In terms of what derangements we see: PTINR prolonged, APTT prolonged, fibrinogen reduced, platelet reduced, FDPs increased, fibrin degradation products, D-dimer, increased. DIC treatments, this is an area that we should just leave to the coagulation experts. It's pretty tricky. So, anyway, yeah. But I think everybody agrees that we should treat the cause. We are all in agreement on that. Whatever is the primary cause, we want to treat it. If we have that in control, we sort of prevent it from escalating. And then we can do all these other things as and when required. PRN. Coagulopathy of liver disease. So when there's chronic liver disease or terminal liver disease, the moment synthetic functions are affected, as you recall, the liver has like a multitude of functions. One of them is synthetic, making proteins and so many other things. So the liver is responsible for making all of these coagulation factors except von Willebrand factor, which is produced in endothelial cells, platelets, and those other places. So now, when the liver is now progressively or chronically faulty, then it means we can also have all of these things prolonged, like we talked about a while ago, except that we won't have the thrombi. There will be, like I'm saying, compared to DIC, for instance, we don't have the microthrombi, we don't have all of those things, but we have all the coagulation screening tests prolonged. In addition, there could also be some bit of platelet dysfunction. There could also be thrombocytopenia from other mechanisms. Other coagulation disorders include things like uremia. The process is complicated. It leads to qualitative platelet defects, and so you see that when you do a platelet function test. The severity depends on the degree of uremia, of course. Okay. Dilutional coagulopathy is a scenario that is described when somebody has received massive blood transfusion. Okay, so the word massive can be misleading because it's used relative to your total blood volume, right? You guys have like 5 liters. The neonate has like maybe 300 mils. So if you give somebody the equivalent of their total blood volume, that will qualify as a massive blood transfusion. Okay. So just remember that in mind, that the word massive is relative to something. The manifestations would include, that's the reason is because when we store blood products, we are storing them at optimal conditions that are designed for red cells only. Huh? So most times when we say we have stored blood, we are storing, conditions are optimized for red cells. If we need to store platelets, we'll have to store them separately, because those conditions that are for red cells don't work for platelets. The conditions that work for red cells don't work for white cells. So, but when we use the term blood banking, you can say default is red cell centric. Okay? They are not designed for clotting factors. So if you need clotting factors, you cannot just transfuse somebody with whole blood that is taken from the blood bank. You'd have to look for FFP, right? Fresh, frozen, plasma. Plasma that was frozen while it was still fresh. FFP. Okay. So that's how we came about this massive blood transfusion leading to dilutional coagulopathy. Disorders of factor inhibitors. Many times these are autoantibodies, but they could also be medications. Okay, and they are usually targeted at factor 8, presenting as if it's an acquired hemophilia. Okay. So laboratory tests of hemostasis by phases. This is useful for you as a reference guide, just to give you an idea of what sort of tests we use to test to examine the integrity of various aspects of the clotting process. I'm not going to talk about these ones. It's repeating many things. Okay, all right. We quickly go on to the second slide. So platelets disorders and thrombosis. We'll try and run through this as quickly as we can. So we'll talk about thrombocytopenia, numbers, and so increased numbers or decreased numbers, thrombocytopenia, reduced numbers or increased numbers as thrombocytosis. Of course, there's a difference between thrombocytosis and thrombocythemia. Thrombocytosis is just saying the number is increased, whereas thrombocythemia refers to that specific condition where the increased platelets is due to some kind of clonal disease. Then, of course, platelet function disorders. Just to remind us, platelets are formed, the great-grandparents, the myeloid stem cells, which then go on to form the megakaryoblast, which then forms the megakaryocyte, which then sheds off its cytoplasm as platelets. Cytoplasmic fragments come off the megakaryocyte as platelets. That's what it looks like. But where they are important to us is when they form the platelet plug, and that happens progressively from platelet adhesion, platelet adhering to the subendothelial connective tissue, and becoming activated, and then releasing all of those granules that then attract more platelets, causing platelet aggregation. This was the graphic I was looking for. So this is the focal site where there is the subendothelial surface has been exposed, and as the platelets pass through, they begin to adhere to it, and then shape change, become activated, release granules, and then there's platelet aggregation. This process then activates the coagulation cascade, which then leads to fibrin formation, this green stuff there, and ultimately the site is sealed off until it completely heals. So thrombocytopenia just refers to that reduced number, which is anything less than this 150. When it's like between 100 and 150, we say that's mild. Between 50 and 100, we say that's moderate. Less than 50, we say severe. And if it goes below 20, sometimes we use the term profound to describe it. And of course, what's the relevance of that? Most times when it's mild, 100 to 150, nothing happens. Yeah. So if there is, when I say nothing happens, I mean if there were to be excessive bleeding with a platelet count of 100 to 150, we cannot necessarily lay the blame at the doorsteps of the platelets. You'd have to look elsewhere to find the cause. Unless, of course, in addition to that, there is platelet dysfunction also. So you have to basically look elsewhere. Now, when it's less than 100, that's when we begin to be interested. Like, now there could be something. So between 50 and 100, there could be prolonged bleeding, but usually there is no spontaneous bleeding. So the bleeding doesn't just start up on account of platelets between 50 to 100. But when the bleeding has started from some other cause, it can be slightly prolonged. When it's less than 50, there can be spontaneous bleeding. Now, the spontaneous bleeding usually would happen in, I would say, maybe not so dangerous areas until it gets to below 20, where spontaneous bleeding can happen in dangerous areas, like intracranial bleeding, intraocular bleeding, retroretinal bleeding, just bleeding in really dangerous places can happen spontaneously when the platelet count is less than 20. Bleeding from thrombocytopenia usually manifests as petechia, this teeny tiny dots of bleeding, petechial hemorrhages. They are best seen on a light skin with good illumination. The darker the skin is, or the darker the illumination, then you're not likely to see it. Okay, so it can also cause epistaxis, bleeding gums, menorrhagia, some increased bruising, though bruising without petechial hemorrhages would not really raise the suspicion of platelets. Ecchymosis, so bruising on their own and ecchymosis without petechial hemorrhages would point more towards coagulation disorders or coagulation factors and other things. And then, of course, it can be responsible for fatigue and weakness. We don't know the reason for that. In terms of diagnosing, obviously you want to do a CBC, and then you want to check everything else that can affect the function of the platelets. So liver, kidney, bone marrow. So obviously we move on progressively as we exclude the non-invasive. You do all of the non-invasive things before you then begin to do anything invasive. So the various causes could be reduced production. Examples include like B12 folate deficiency, leukemia, myelodysplasia. So some of these, like leukemia, for instance, just the environment is not conducive for making things, or maybe space is not available or nutrients. Dysplasia is when you have the stem cell itself being faulty, so just broken stem cells. Aplasia is when the marrow environment or maybe the seed is just not good. So the stem cell is faulty in aplastic anemia. Then liver disease, sepsis, all of those things can, consume the platelets or just lead to increased, reduced production. Remember that the liver is responsible for making thrombopoietin. I think I should point that out. Thrombocytopenia in terms of increased destruction can come from, say, ITP, which is probably the most dramatic of them all, and then of course TTP, which we have come to know is a problem with ADAMTS13. Then we try to separate that from HUS, hemolytic uremic syndrome. Then we've talked about DIC a bit, antiphospholipid syndrome, all of those other conditions listed. Other causes include medications and then some other things, snake bite, which is not really something we should be talking about in New Zealand, right? We just ship that over to Australia. ITP is pretty dramatic. ITP, you find somebody who is completely well for all intents and purposes, just walks in and they have some inconsequential minor bleeding episode, maybe just increased bleeding after brushing, or they just notice a bruise somewhere or a dot on their skin, some petechial hemorrhages, and to your surprise you do the full blood count and you find blood platelets of like 1 or 0, you know, and you're like, okay, how is a platelet count of 1 compatible with this person walking in, right? It just looks, so it's one of those conditions where patients will like look at you and those numbers are wrong. you know, so ITP is just so many times patients with ITP present with bleeding that appears to be disproportionately mild as compared to the degree of thrombocytopenia. Many times platelet counts are less than 10,000 per microliter. Actually, most times platelet counts are less than 10,000. So that's the classical presentation for ITP. And you obviously won't find any other immediate obvious cause for the low platelets in that scenario. It's very difficult to diagnose because it's not we are not required, because it's difficult to prove. We are not required to prove that there are actually antiplatelet antibodies in circulation, but when we look for them, we would find them. But we are not required to prove it, and the urgency of the situation requires that you intervene before you are able to find the time to prove this. So many patients will just get their steroids on the same day they present. Yeah. So when I talked about platelets less than 20,000 causing spontaneous bleeding, usually that is not true for ITP. You don't find that kind of spontaneous bleeding or bleeding in dangerous sites with ITP. Because the problem in ITP is not that the body is not making platelets. The body is actually making excessive amounts of platelets to keep up, but they are all being mopped up in the peripheral circulation by these antibodies. So generally speaking, they don't get severe bleeding episodes or bleeding in dangerous sites. It's just that you find these very low levels of platelet count in an otherwise healthy person. Many cases also have been attributed to a prodrome, like a viral prodromal illness, a few days or weeks before the ITP. So will manifest as listed: epistaxis, menorrhagia, spontaneous purpura, all of those things can happen. Very uncommonly, we find people with intracerebral or subarachnoid hemorrhage, but that's not the usual. ITP, in terms of treatment, we would use steroids as the first line, and if that doesn't work, we may go on to anti-D, immunosuppressive agents. Now, many times when patients have their first presentation, the acute presentation of an ITP, if it's in children, Actually, the pediatricians will probably do nothing. They will just send the child home. And in adults, we would usually give something. And in children, the classic the classic history of the disease is that it spontaneously remits. It just disappears on its own and never comes back. Whereas in adolescents and adults, they go into remission, most cases after some intervention, some immunosuppressive agent has been given acutely, and then relapse soon after that, and then become chronic and sometimes lifelong. So yeah, in adults, chronic ITP is the norm. In children, acute ITP is the norm that spontaneously remits and never comes back. TTP, it's a rare disease with extensive microscopic clots in small blood vessels. It is associated with consumption of platelets by thrombus formation, leading to a decrease in circulating number of platelets. The problem is due to an enzyme that is responsible for cleaving von Willebrand factor. In the absence of that enzyme, which is the ADAMTS13, in the absence of that enzyme, large multimers of von Willebrand factor are formed, which then lead to platelet activation and then causes this abnormal thrombosis. So it can develop. It could be autoimmune, which is acquired. It could be genetic, maybe hereditary. So there are hereditary forms of it. There are acquired forms of it. In terms of symptoms and signs, as listed, mortality can be quite high in untreated TTP, but in cases that are properly diagnosed and treated, it can be managed successfully. Platelet transfusion is contraindicated because it just fuels the coagulopathy. The appropriate therapy is plasmapheresis to try and remove these abnormal antibodies, and then immunosuppression, of course. HUS can present like a TTP, but the origin is the pathogenesis is completely different. So here we are getting toxins from some microorganism that typically would cause a prodromal diarrhea infection. And then after the diarrheal infection is supposedly gone, then you begin to see the effect of the toxins, pretending to be some kind of haptin or something, binds onto some renal cells and then causes platelet activation, thrombosis, and of course the damage is concentrated in the kidney and the CNS. So prodrome of diarrhea, specific organisms have been finger pointed. So E. coli Shiga toxins binds to this glomerular endothelium and becomes thrombogenic and then induces something like a TTP. And that's why it's, clinically speaking, it's very difficult to differentiate a TTP from an HUS. Older books will just lump them together, HUS, TTP, because historically we couldn't tell the difference between the two of them. We just called them the same thing. But over time, we've been able to separate them. But clinically, it's still a challenge to try and tease them apart when you are faced with a case. It's not that easy to separate. Okay, so this is what it looks like. So a preceding diarrhea infection, thrombocytopenia, hemolytic anemia, renal impairment, cerebral convulsions or confusion, seizures, all of that can happen. In terms of treatment, it's usually supportive. You monitor until resolution of diarrhea illness, hemodialysis if indicated, plasmapheresis is contraindicated. What is the treatment for one is contraindicated in the other. So you really need to separate them. All right, HELP. HELP syndrome is hemolysis in the presence of elevated liver enzymes and low platelets. HELP. hemolysis, elevated liver enzymes, low platelets. Okay. Described in the context of pregnancy, as this picture shows. So it's a complication seen in pregnancy with preeclampsia due to endothelial cell injury that induces platelets and coagulation cascade activation, leading to the thrombosis and then thrombocytopenia and red cell fragmentation. So many of these conditions we screen for them also. Sometimes we're just looking for these red cell fragments in the peripheral blood. So symptoms and signs as listed. Thrombocythemia now. So thrombocythemia, like we said, is a scenario where increased platelet count is due to a clonal disorder. So there is some myeloproliferative process or pathology that is driving an increase in the number of platelets. You can think of it like some cancer of platelet production, of the platelet producing cells. Right? Okay, so that's what it is. Definition, increase the number of platelets. Technically, we want to see at least 450 platelets persisting for at least 3 months before we begin to entertain the possibility, and then we screen for it. We will just do a JAK2 screening and a BCR-ABL, which are the molecular tests you do to screen for myeloproliferative neoplasms. So BCR-ABL is to screen specifically for CML, and JAK2 is to screen for essential thrombocythemia and or PV. But in the context of a thrombocytosis, it is the relevant ones will be CML and essential thrombocythemia. Symptoms, most times asymptomatic. We just pick it up casually. If it's really very high, the platelet count is really very high, there could be some manifestations like erythromelalgia. This is a burning sensation of redness in the extremities, may be confused with gouty symptoms if one is not careful, because this one also tends to happen in big toes. There could also be DVT and PE. So generally just thrombosis. There could also be splenomegaly or bleeding due to platelet dysfunction. So you would imagine that when platelets are increased, there shouldn't be bleeding, but in this condition, there can be bleeding. So there can be thrombosis, there can be bleeding. All right. Okay. So in terms of thrombocytosis, this is poorly. So the heading there should be thrombocytosis. In terms of thrombocytosis is most commonly caused by reactive reasons. Okay, so it says here 97%. Okay, so as much as 97%. 97 out of 100 times when people have increased platelet count, it is due to some reactive process. Of course, the commonest cause is trauma, bleeding, all of those things that tissue injury, those are the things that commonly cause thrombocytosis. And if somebody were to do platelet count on a daily basis, and that person happens to be female, you would find that during that period when they have the menstrual bleed, actually the platelet count goes up and then comes down after the period. So commonest cause, please remember, commonest cause of thrombocytosis is reactive. Only few cases, extremely rare cases, would turn out to be something like the cancer we described previously. Clonal thrombocytosis or thrombocythemia. These ones are generally seen in the context of this so-called MPNs or myeloproliferative neoplasms. And the classic MPNs are essential thrombocythemia, chronic myeloid leukemia, polycythemia vera, and primary myelofibrosis. Essential thrombocythemia is a cancer of megakaryocytes, chronic cancer of megakaryocytes. We used to call these diseases chronic myeloproliferative disorders. So this is the one affecting the megakaryocytes, and typically driven by a mutation of the JAK2 gene. In terms of treating these patients, we use aspirin a lot because it can disrupt platelet function. So we want these platelets to be dysfunctional, even though they are present in a lot, in high numbers. We want them to be dysfunctional so they don't cause thrombosis and all those other things. And when the counts are becoming unmanageable, we can use cytoreductive agents like hydroxyurea. Some people may also go as far as doing platelet pheresis. Just remember, if you remove platelets from somebody with essential thrombocythemia, it's not meant for donation. You can't use it to treat somebody else. That's a cancer. Okay. Platelet function disorders. There are lots of things that can go wrong with platelets. Some of them are congenital, some are acquired. The acquired ones are more common. So we talked about aspirin. Okay, all right. Thrombosis. Thrombosis happens usually due to some dysfunction in this triad: endothelial injury, hypercoagulability, abnormal blood flow, the classical Vicos triad. Endothelial injury leads to platelet activation and thrombus formation, while alterations in blood flow leading to turbulent flow can also cause endothelial injury. Stasis can contribute to that. Hypercoagulability from primary genetic inherited things or some acquired pathology. Some risk factors that have been identified: prothrombin gene mutations, factor V Leiden, antithrombin 3 deficiency, and all of those things listed. Secondary risk factors include malignancies, pregnancy, surgery, stasis. Arterial thrombosis is completely different from venous thrombosis, okay? Obviously, one of the biggest differences is the fact that arterial thrombosis can embolize and can go to the brain, can go to many other organs, whereas venous thrombosis, when it embolizes, it goes to the heart and ends up in the lungs, okay? It doesn't go beyond that, except in very rare instances that you guys are familiar with from ELM. Venous thrombosis most commonly due to venous stasis. It can be superficial or deep. The relevant one most times is the deep one, so it's a deep vein thrombosis, and that happens in femoral or popliteal vein. These are veins that have valves in them, and when those valves become defective, then that's part of the reason for that. But it's important to point out that when we have a clinical suspicion, which we can gauge using what we call a pretest probability, when the probability is very low, we can further do screening with D-dimer. If it's negative, that means there's no thrombosis. If D-dimer turns out to be positive, then we go back to a confirmatory process test like a compression ultrasound scan. Or if indeed we have high probability from the pretest probability, we go straight to the compression scan. So this is pretest probability when we are trying to test for the possibility or the chances that someone might have a DVT. We can go through all of this, and when it is greater than or equal to 2, then it's likely. Then we go ahead and do a scan. We'll probably do the D-dimer, and when we confirm that, we go on to the compression scan. When it is very high probability, we can just skip on to compression ultrasound. The compression ultrasound scan is just to see that there's a filling defect, to find if there's a filling defect within the vessel wall, within the vessel lumen. Likewise, when we look at, when we have a case of suspected PE, pulmonary embolism, we can do the Wells, check the Wells criteria, which is the pretest probability for that. As you might recall, to confirm a PE, you would need a CTPA, which is expensive, logistically challenging procedure to do. And if somebody were to be located remotely, it's a big decision, right? So you want to be sure that indeed there is a good reason to do it. So that's the role of the Wells criteria. Again, if we do this and we find that it is likely when we score above 4, then we'll proceed with a CTPA. When it is not so likely, we might say, okay, well, just as a final confirmation, maybe we want to do a D-dimer also and see if it seems like it's unlikely. In terms of treating them, we use anticoagulants. Heparin is fast onset of action. It's available IV, and so you can easily get it to start working immediately. As opposed to warfarin, which is orally available and takes like 3 to 5 days for it to take effect. So anticoagulants like heparin, we can monitor with the use of the APTT to see at what point whether we have achieved the desired prolongation in APTT. Warfarin, like we said, can be used, orally available, obviously, and also very cheap. It acts by blocking vitamin K. Newer agents like dabigatran can also be used. These ones, the big advantage for the newer agents is that they don't, I didn't mention that for warfarin we would monitor with an INR. Okay, in New Zealand we use, there's an online INR website that is used to monitor these things. Can be done at local pharmacies, and the dosage of warfarin can be adjusted up and down as required. So as you can see, with heparin and warfarin, you require some form of monitoring. Either you are monitoring with the APTT or you are monitoring with the PT INR. Whereas with the newer agents, they generally don't require monitoring, and they are orally available, relatively easy to take. Most times they're like once a day. I didn't also mention that warfarin is notorious. If there's one thing you guys must have learned in pharmacology, is that warfarin sort of interacts with everything, and so people want to avoid it as much as possible. So talked about this. Aspirin, the role is mostly prevention. So when we're trying to prevent secondary thrombosis. Okay. Questions, comments? None? All right. Thanks for your attention. I'll see you guys next time.